Greetings to everyone. I would like to thank the team Oral Pathology 360, Professor Dr. Madam Mandana, for inviting me to present a topic in this forum. I would like to be presenting today on biphasic tumors of maxillofacial region. Myself, Dr. Santosh, oral and maxillofacial pathologist. I'm currently employed at the University of West Indies Mona campus, Jamaica. Before I begin this presentation, I would like to thank my postgraduate teachers who actually introduced this particular topic during my postgraduate period. My thanks to Professor Ramana Reddy, Sibar Institute of Dental Sciences, Dr. Anuradha Madam, Dr. Chandrasekhar sir, and Dr. Kiran Kumar sir, Dr. Shamla Ravi Kumar Madam. So with this note, I would like to continue my presentation. Upon completion, the listeners will be able to demonstrate the ability to integrate biphasic concepts while identifying biphasic or bimorphic tumors from oral maxillofacial pathology literature, and should be able to properly exclude the tumors that mimic as biphasic or bimorphic tumors from our oral pathology literature, and demonstrated understanding of the concepts of biphasic and bimorphic tumors, and should be able to list the various available biphasic or bimorphic tumors from our oral pathology literature. The contents of this presentation are introduction, biphasic versus bimorphic tumors, theories on biphasic tumor development, discussion of biphasic tumors, bimorphic tumors, and histologically mimicking biphasic tumors. Finally, I will be concluding and share my references. The aim of this presentation is not to give you the microscopic explanation of the tumors that I'll be discussing, but to tell why these tumors are categorized as either biphasic or bimorphic tumors. So let me begin with the introduction by looking at the nomenclature. Biphasic tumor means it is a truly and histological term that refers to neoplastic tissue, which is characterized by two different cellular elements. The term biphase says us that there are two different phases, and it supports the fact that origin of tumor is from two different cells. However, the biphasic tumors can be used in condition where the tumor tissue is characterized by two different cell populations and where both cell populations demonstrate malignant nature microscopically. I'm saying this definition because the term biphasic is widely used in our literature, pathology literature, where even the benign tumors has been categorized as biphasic because it can show two different cell populations. But when you look deeply in most of the literature, most important literatures suggest that biphasic tumors is representing two different cell populations in terms of malignancy. In contrast, the tumors that are characterized by two different cell populations, where one cell population is malignant, is termed as bimorphic. In simple words, bimorphic tumors meaning there are two different cell populations. One cell population is definitely a malignant, the other one can be a benign or a non-neoplastic cell proliferation. So as I said, in the literature, I started searching for it, and I found this was more supportive for my presentation, where it defined the biphasic tumors as a group of tumors that are composed of two elements, malignant epithelial and mesenchymal components. And this is taken from the Diagnostic Pathology article from Springers. So let me take a schematic picture for my explanation here. As we all know, in normal, we have epithelium and connective tissue in our specimens. In case of malignancy, we have either the malignancy representing in the epithelium or in the connective tissue. Biphasic tumor represents the malignancy in epithelial and mesenchymal or in a connective tissue, right? Or it can also simply mean that malignancy within the epithelium can show two different cell population, or within the connective tissue, you can have a two different cell population which is showing malignancy. Whereas in bimorphic, you have one malignancy either from epithelium or from connective tissue, and you can have a non-neoplastic proliferation either in connective tissue or within connective tissue or within epithelium. So how a tumor can get a biphasic or bimorphic presentation? As we all know about a tumor microenvironment, right? The tumors are characterized by co-proliferation of epithelial and mesenchymal elements. The interaction between epithelium and stroma is essential in the normal development and repair of many organs. And similarly, the same interactions presumably contribute in the formation of certain benign and or malignant solid tumors. So I believe the backbone of this presentation is this slide, or next two slides. The theories that explain the biphasic nature of the tumor are: 1, the collision theory; 2, the combination theory; 3, the conversion theory; and the 4, the composition theory. Let us look what this theory says to us. First, the collision theory suggests us that two components of tumor are two independent neoplasms. The combination theory suggests that both components are derived from one single stem cell that undergoes a different or divergent differentiation early in the evolution of the tumor. The conversion theory suggests that second cell component of the neoplasm derives from the first cell proliferation of the tumor. And the composition theory suggests that the second cell component is a stromal reaction to the presence of first cellular component. This stromal reaction can be either neoplastic or non-neoplastic. So I would like to confirm that all these four theories are speaking the truth, and it's trying to explain the concept of biphasic tumor. So this is the backbone of our presentation, and it will explain us how it is going to explain in various tumors that we are going to look at it. So the term biphasic or bimorphic tumors that were identified in our literature are that various tumors are: 1, spindle cell carcinoma; 2, nasopharyngeal carcinoma, which is undifferentiated type; synovial sarcoma; carcinosarcoma of salivary gland; melanotic neuroectodermal tumor of infancy; epithelial-myoepithelial carcinoma; and mesenchymal chondrosarcoma. And the tumors that histologically mimic biphasic tumors are myofibroblastoma and neurolemoma. For a better understanding, I tried to put the same categories over there into in a different version here. So the biphasic tumors from the list are carcinosarcoma of the salivary gland, spindle cell carcinoma, epithelial-myoepithelial carcinoma, mesenchymal chondrosarcoma. So this is trying to indicate that you have two malignancy here, two malignant cell population. Bimorphic, as you know that one of the cell population is definitely malignant, and the next one can be non-malignant or reactional. So spindle cell carcinoma, this is represented in both biphasic and bimorphic. When it comes to the slide on spindle cell carcinoma, I'll tell you why it is listed both. Nasopharyngeal carcinoma, undifferentiated type; synovial sarcoma, melanotic neuroectodermal tumor of infancy. And the mimicking biphasic tumors are myofibroblastoma and neurolemoma. Biphasic tumors, I like this picture because you can see the two heads there, both are malignant, meaning both are tiger. Both are harmful beings. The first one in our discussion, the carcinosarcoma of salivary gland. It is a true malignant mixed tumor in which both the stromal and epithelial components fulfill the histological criteria of malignancy. Microscopically, we see both carcinomatous and sarcomatous elements in this specimen. The sarcomatous component are dominant in this tumor, specifically chondrosarcoma type, and carcinomatous type is represented by the ductal adenocarcinoma. So this literature is taken from a publication, Dimitris et al., published by Dimitris et al. And you can see the histological picture here. In this area, you see a carcinomatous component of the large ductal structure and the carcinomatous sarcomatous component showing the multinucleated giant cells here. So you have both carcinomatous and sarcomatous component in one single tumor, and that is why we call it a biphasic tumor here. So as I said earlier, I'm going to discussing the concepts behind this particular tumor to be categorized biphasic. There are two antithetical hypotheses here. So one is a convergence theory and another one is a divergence theory. The convergence hypothesis supports the polyclonal nature of the tumorigenesis, and it suggests that origin of carcinosarcomas is from two or more stem cells. The convergence theory explains that carcinomatous component is driving force and that sarcomatous component develops eventually during a tumor progression, and that this particular concept is supporting the conversion theory concept of biphasic tumors. The divergence concept of this particular tumor, the divergence theory supports a monoclonal nature of tumorigenesis, and it suggests that origin of carcinosarcoma is from a single totipotent stem cells that differentiate into separate epithelial and mesenchymal components. The divergence hypothesis supports the combination theory. The next is a spindle cell carcinoma. Spindle cell carcinoma is characterized by some elements resembling a squamous cell carcinoma that are associated with spindle cell component. In true spindle cell carcinoma, the malignant spindle cell shaped cells should demonstrate epithelial origin and derived from squamous cell component of the carcinoma. So this is trying to say the combination theory, as you see that it's derived from one single stem cell. So this is supporting the combination theory. The literature also suggests that spindle cell carcinoma must be distinguished from spindle cell carcinoma that has provoked a reactive fibroblastic stromal proliferation, which is trying to support the composition theory. There is a carcinosarcoma in which a spindle cell carcinoma is accompanied by a sarcoma or fibroblastic or another type of connective tissue tumor, which means that it's a collision theory. Histopathologically, the spindle cell carcinoma specimen shows a foci of epithelial dysplasia, that is one cell population. Now another cell population being spindle cell elements that is proliferating at the basal cell level, which we call as a dropping off phenomenon. And next thing is the epithelial-myoepithelial carcinoma. Epithelial-myoepithelial carcinoma is a low-grade malignant salivary gland tumor. The biphasic appearance of epithelial-myoepithelial carcinoma is due to the presence of ductal lining cuboidal cells, which is one cell component, the another cell component, which is the clear cell component, which is seen in the microscopic specimen. The histocharacteristics of epithelial-myoepithelial carcinoma shows the expression patterns of both epithelial and myoepithelial cells, supports the biphasic appearance of the tumor. The pluripotent stem cells in the salivary gland system differentiate into acinar and ductal cells. Acinar and ductal progenitor. The myoepithelial cells take an origin from the acinar progenitor. So that is where the clear cell is coming up. And you know the ductal component of the ductal carcinoma is coming from ductal progenitor cells. So it is trying to say that it is taking from a single stem cell, that's a pluripotent cell, that undergoes divergent differentiation. So hence, this is supporting the combination theory. So this is a case that I would like to show from the literature. You can see on the left-hand side, the polygonal clear cells on this side, and you can see the cuboidal cells on the right side. At this moment, I would like to give a connect with another presentation from Oral Pathology 360 lectures, where Dr. Karpaga Selvi Madam spoke about clear cell lesions, right? So in that video, I think at around 33 minutes, right? So we can see her explanation saying two components about the epithelial-myoepithelial carcinoma. We can see a clear cell and a ductal cell. I'd like to thank at this moment Dr. Carcinosarcoma madam for that presentation, which was helpful to connect in my presentation. The next topic in discussion is mesenchymal chondrosarcoma. Mesenchymal chondrosarcoma is a histological variant of a chondrosarcoma. Microscopically, it is characterized by varying amount of two cell components, remember? So one is a cartilage component and the next one is undifferentiated small round or ovoid cells. Although a two cell population is observed in mesenchymal chondrosarcoma, both cell populations are derived from single cell lineage. And again, this is supporting the combination theory, which suggests that it is coming from one single stem cell, which undergoes a divergent differentiation to show two cell population. So this is an evidence or a case example published in Journal of Oral Maxillofacial Pathology, our association journal by Dr. Majumdar et al. On the left-hand side, you can see a chondroid areas, and on the right-hand side, you can see the round ovoid cells. So on the same case, so it shows a two different cell population and considered to be a biphasic tumor based on a combination theory concept. Bimorphic tumors, one being dangerous, and that is a malignant, other one being can be a neoplastic, but is a benign component or a stromal reaction component. And I found that this picture could be a good example, having a cat on one side and a tiger on another side. One is being dangerous, and another one being non-dangerous. Under this, we have a nasopharyngeal carcinoma. This tumor represents a malignant tumor of the lining epithelium of nasopharynx. Based on the keratinizing character of this particular tumor, nasopharyngeal carcinoma is divided into three types: well-differentiated squamous cell carcinoma type, keratinizing carcinoma type, and undifferentiated carcinoma type. So out of these three types, the undifferentiated type of nasopharyngeal carcinoma is considered as a biphasic type or a bimorphic type. Microscopically, the tumor is characterized by solid sheets of large tumor cells which are arranged in the irregular islands. The tumor cells are intermingled with the inflammatory elements. So one cell population is actually tumor cell population, and the second cell population is inflammatory cell population, which is predominantly lymphoid component. And initially, people used to think that lymphoid tissue was a derivative and it is a non-neoplastic, right? So all the two types of proliferation was observed. One is being neoplastic and another one is a non-neoplastic, where in this case is inflammatory. So this supports the composition theory and is a bimorphic tumor and not a biphasic tumor. Just a slide showing from Head and Neck Pathology Journal. So you can see a two cell population here. This is a high power view. You can see this is actually sheets of the malignant cells, and you can see the background of lymphocyte proliferation. So this is undifferentiated type of nasopharyngeal carcinoma, and this has no keratinization in this type. There's an absence of keratinization. The next topic here is synovial sarcoma. Synovial sarcoma represents a tumor arising from the synovial tissue that presents both lining cells and subsynovial stromal cell. It arises from the pluripotential mesenchymal cells near the joint surfaces, tendon sheets, juxta-articular membranes, and facial aponeurosis. Microscopically, it is characterized by two strikingly well-distinct cell populations, one being spindle cell element and another one being epithelial component. In addition, it is worth to know that two predominant types are seen. Here, they use the term bimorphic and monomorphic because sometimes what happens, it can show both components as a presentation, or it will just show you only one component in the presentation. When you see only one component in the presentation, histopathological presentation, we call it a monomorphic, which shows predominantly spindle's component. When it's bimorphic, it shows both spindle shell and epithelial components. Synovial sarcoma arises from the primitive cells that have the potential to differentiate into either mesenchymal or epithelial components. While looking at it, why this is categorized as a bimorphic tumor and not a biphasic tumor, because it is showing only one element of being malignant. Based on the histogenetic origin of the Synovial biphasic tumor is explaining to us by a combination theory where it shows derived from one single cell, single stem cell, and can differentiate into either a mesenchymal or epithelial component. This is a picture, another picture coming from the Journal of Oral Maxillofacial Pathology journal published by Dr. Vijay et al. You can see on the left-hand side, the epithelial islands here, right? And then you can see the epithelial islands, and on the right-hand side, you can see a spindle cell islands in this picture here. This is another case which is published in Journal of Research in Medical Sciences, Mariam et al. This particular is a monomorphic type of synovial sarcoma. It is prominently showing the spindle cell type, and there's no epithelial component. So there's a monomorphic type of synovial sarcoma. The next thing is a melanotic neuroectodermal tumor of infancy. This lesion is also considered as a biphasic tumor. And as we all know that this is a benign version of the tumor, but it's aggressive. And probably that's the reason why it should be considered in the biphasic tumor, because it's locally destructive. Melanotic neuroectodermal tumor originates from the neural crest cells, which primarily affects the jaw of a newborn infants. Microscopically, it is characterized by biphasic population of pigmented and non-pigmented cells. These are two different cell populations that we see it in the dense background of fibrous connective tissue, where you can see in this picture here, we have a pigmented cells and a non-pigmented cells here. And these are actually the epithelial-like cells arranged in the form of small islands in the form of acinar or glandular structure. And you can see these cells in here, which is a pigmented, some of them. The second group of cells is generally grouped, but they are not very cohesive, which may be seen as islands, or which are occasionally arranged in the form of bunches or surrounded by the pigmented cells. So the epithelial nests that evolved at the time of the embryonic fusion during the facial process are responsible for the origin of this tumor. This statement supports the combination theory and explains the biphasic nature of this tumor. The next thing is a histologically mimicking biphasic tumors. You have the picture that shows, which is actually a cat which is looking into the mirror and looking as a tiger, like a benign tumor which is looking as a malignant, or a tumor that is actually mimicking as a biphasic. Two categories under this, myofibroblastoma and neurolemoma. Myofibroblastoma is a benign stromal tumor of mesenchymal origin with a myofibroblastic differentiation. Microscopically, the tumor tissue is characterized by spindle-shaped cells. This tumor shows a wide spectrum of morphological appearance, and there are almost 8 variants here that includes cellular, infiltrating, epithelial, deciduoid-like, lipomatous, fibrous, myxoid, and mixed variant. So one of the commonalities has an epithelial variant, which shows both epithelial variant, which is like epithelial component, and a spindle cell component, which tries to give an appearance of 2 different cell population, and that's why it was considered as a mimicking component, because it's a benign. So because of the 2 appearance, it was considered to be a biphasic appearance, but is actually mimicking tumor. Epithelial-myoepithelial is characterized by epithelial cells predominantly and variable amount of myxoid or fibrostoma. The epithelial and stromal components of the tumor mimic the biphasic tumor. It's not all the types are biphasic nature. Mimicking biphasic is only one component, that is epithelial version. The next thing is a neurolemoma. Neurolemoma is a benign neuroplasm that originates from the squamous cells. This is considered to be a bimorphic or a biphasic tumor because of this pattern of appearance. As we all know, there are 2 patterns there, Antony A and Antony B pattern. So it's considered to be like a biphasic, but it's truly not a biphasic because it's not a malignant tumor and it's not representing the bimorphic pattern. So my take-home messages for this presentation are, biphasic is a term should be used with an understanding on the framework of tumor biology. And biphasic is a term that do not necessarily indicate the microscopic pattern of malignant presentation, however, recommends the origin of neoplastic process. Biphasic is a term to be used when 2 cell populations are malignant, whereas the term bimorphic should be used when one cell population is malignant and another is non-neoplastic. Although this particular slide is not directly related to our slide, okay, but I would like to connect this slide in our presentation for a reason. And this is stated by Saman Varnakula Surya et al. And I would like to recall this a statement from this publication where he spoke about a nomenclature of oral potentially malignant lesions, where he said that we will not succeed in recommending certain terms in universally used be summarily abandoned, but must lead in educating how these terms should be used within a framework of international consensus. So here the reason for using certain terms should be something about the educational framework and how it can be employed in our clinical setting. So I'd like to use this particular statement in concluding this presentation. The term biphasic tumor and bimorphic tumors are to be cautiously used while understanding the origin or the tumor biology or cell population of the pathology and its relevance in diagnosis and management directives of a patient, and not just because of presence of two cell population. If that is the case, I would like to give some examples, which I think should also be considered as a biphasic, like papillary cystadinoma, lymphomatosome, where you have two cell population like appearance, one you being, double layered epithelium, and another one we see a lymphoid stroma, or even an amyloblastoma, which shows actually like in a tall columnar cells and you have a stellate cells, or amyloblastic fibroma, where you have an derivation of the epithelial and mesenchymal component. So in terms of papillary cystadinoma lymphomatosome, there's a Watt's tumor, and amyloblastoma should not be considered as a biphasic because it's not coming from the concept of biphasic. And I think we should restrict these terms to the malignant use. And one of them at least being a malignant, or both being malignant, being a biphasic or a bimorphic to be used when one being malignant, another one being non-malignant. I think amyloblastic fibroma can be something slightly close to the biphasic explanation, but it's a benign, so I'm not including in this, and I don't see any literature speaking amyloblastic fibroma as being a biphasic, although amyloblastic fibroma has both epithelial and mesenchymal component. So finally, I would like to say that biphasic tumors is a term that we should restrict to the malignant related when it is both are being malignant. When one being malignant and another being non-malignant, we should restrict them to be a bimorphic tumor. And this term should be used in terms of malignancy. So these are my references, and there's a paper that was published from this particular topic. And if you can scan this QR code, the persons who would like to interest a full paper can scan this QR code, and I hope that you'll take you to the full paper of the biphasic tumors. So thank you for this opportunity, Dr. Mandana Madam and Oral Pathology 360. And I really hope many of you would feel this topic is worth listening and it will be helpful for your postgraduate learning. Thank you all.